So today I would like to give you two presentations back to back. One is about stabilizing keratoconus. The other is to improve keratoconus. And I will start with the sub 400 protocol, which is aimed to stabilize extremely thin corneas. May I ask you, how many of you happen to use that protocol or any protocol for thin corneas? Okay, thank you. So you all know that the 400 micrometer rule was established by Sperl and Seiler back in the late 1990s as a response to the technical settings of the time. 3 milliwatts times 30 minutes gives you a certain depth of treatment. And in order to protect the endothelium, you take a safety margin of maybe 60, 70 micron, and you end up with 400 micron. But in clinical reality, we are often facing corneas like the one above. So what do we do in a 220 micron cornea that still could have good vision with a scleral lens, but is progressive and does not fit the criteria? Well, back in 2007 and 8, our group in Zurich established the first thin cornea protocol, which is swelling of the cornea with hyperosmolaric riboflavin. This is how we started treating corneas that were thinner than 400. And a few years later, Susan Jacob from India said, you don't need to swell the cornea, put a contact lens on the cornea. So that's contact lens assisted cross-linking. So in other words, this is how I explain it to my patients. If I have a thin cornea, I can either swell it or I put something onto the cornea to make it thicker. In other words, the swelling is due to an osmotic pressure. And so I have water going into this cornea. And the question was, how good is biomechanics if you do this? If you swell such a thin cornea, biomechanics is really good. Wollensack published on it. It's just as good as in a regular thickness cornea. So we do a good thing in principle, but I do not use this technique of ours anymore. Why? Because it's unpredictable. When you go onto the patient to do the abrasio, you want to see a swelling of the cornea, and some patients swell a lot, others don't want to swell, and then you have an issue. If you are at 320 micron and you swell and swell and swell and nothing happens after 10, 15 minutes, that's frustrating. And in some rare occasions, I had to tell the patient, sorry, your cornea doesn't want to swell, I cannot perform the cross-linking. So this is why I don't use the swelling anymore. Why don't I use contact lens assisted cross-linking? It sounds so easy and it would make so much sense. You have a cornea and you simply put something on top. Well, I'll show you why. We published 12 years ago that oxygen is essential for cross-linking. You see the red column, that's cross-linking without oxygen. It doesn't really work. And the contact lens blocks oxygen. The best contact lens in the world still blocks oxygen. So 1 year after Susan's paper, we published the efficacy of contact lens assisted cross-linking, and it was 30% reduced. Wollensack did the same thing 4 years later, again 30% reduction of efficacy. So if you do contact lens assisted cross-linking, you induce some cross-links, but not many. So we were looking for a technique that would make more sense. And specifically, what we have been doing until now was we have a technique. My cornea doesn't fit the technique, so modify the cornea. Does this really make sense? Or would it make more sense to do the opposite? Adapting the technique to the cornea, not the cornea to the technique. So we went back to a blank piece of paper and asked ourselves, how can we modify cross-linking for thin corneas? What we have been doing the past 10, 15 years was modifying thickness artificially, swelling, contact lens. Can you think of any other way how to treat a thin cornea? One way would be to change riboflavin concentration. If you go from 0.1 riboflavin to 0.2 riboflavin, you have more molecules in the upper part of the cornea at this position. So you will induce more crosslinks with the UV light in the superficial cornea. The higher the concentration, the more shallow the effect. So this could have been a way to do it. just say for a 200 micron cornea, you need 0.6% riboflavin. For a 300 micron cornea, you need 0.4. Imagine your stock. You would need 10, 15 different riboflavin solutions. Doesn't make sense. What makes most sense is to vary what is the easiest, to vary the intensity. Because that's simply a setting on your lamp. And this is what we did. We developed this algorithm, published on it back in 2017. And what the algorithm does, it calculates the amount of energy needed to stop 70 micron before the endothelium, no matter how thick your cornea is. It's an epi-off procedure. We published this in the American Journal. So no matter how thick your cornea is, you can check the thickness. So you do a normal epi-off. You put your riboflavin in for 10 minutes. You don't swell. You just put on riboflavin for 10 minutes. Then you measure thickness, and you go with that table. So again, one more time, what we did was, before that sub 400 protocol, we had a fixed fluence, let's say Dresden, 5.4, or 10 minutes at 9 milliwatts. So you would treat down to a certain depth. But if the cornea was too thin, like the one on the right, 300, then you would treat the endothelium. So we did artificial increase in thickness, swelling contact lens. What we proposed was adapt the fluence. So look at the fluence here and these two fluences. And this is the sub 400 protocol. So instead of going to 30 minutes for 400 micron, if you have 300 micron of stroma, you go for 10 minutes. If you have 240, you go for 2 minutes 30, and so on. So adapting the fluence. We integrated the sub 400 into the CI device. So for the ease of use, the entire nomogram and algorithm are present here. And the original data were 1 year follow-up data with a success rate of 89%. Surprisingly high for me. I didn't expect such a high percentage because we were cross-linking extreme corneas, 70 diopters, 80 diopters, 85 diopters. Now the new data. At last year's ESCRS, we presented the same cohort with the 2 year follow-up. And what we saw was K readings further showed a small but significant flattening. Success went down from 89 to 82% after 2 years. But again, 82% in such corneas. This one was more than 90 diopters of Kmax and still stable and still good vision with the scleral contact lens. This was the thickness profile. So in the meantime, we used the sub 400 protocol to treat keratoglobus, the last remaining ectasia that could not be treated. And then in conclusion, we can go down to 200 micron with this first generation treatment. We can treat keratoglobus. But as you know, it took us several years to develop. We published in 2021. In the meantime, in 2020, we started the second generation sub 400, and this one will be submitted in the next weeks. Where's the difference to what you're using now? We increased the total fluence. So the starting point is not 5.4 joule, it is 10 joule, and we accelerated. That was a demand of many. And you will see the entire table in a few months once it's published. I'll just show you a ballpark. So this is the first generation, and this is the second generation. See, we went up to 10 joule at 400, and then at each given thickness, we have way more total fluence. And this one seems to be even a little more stable than the first generation sub 400. It will be published soon. We had colleagues from Unifesp in Brazil. Should know that ELSA is tiny. We have exactly one person dedicated to research. So as much as we would like to move very quickly, we need external help too. So we outsourced the endothelial determination, the endothelial measurements to Unifesp, Sao Paulo. And even with the second generation sub 400, there is no change in thickness and no change in endothelial cell count. I think this was between 25 and 30 eyes measured. So this is comforting. So even the 10 joule, they don't seem to impress the endothelium too much because we adapt the fluids to the thickness. So there is not a disproportional effect on the endothelium. So as I told you, first generation sub 400, that's the one that you are using now. What is coming this year is the second generation sub 400. But what we have been working on since last year is the Holy Grail Epi-on sub 400. And this one should be ready in a year to two. Our aim is for you to do an Epi-on treatment in any thickness cornea as long as vision is satisfactory. And this one we have just started. That's based on the Epi-on we developed in the past 3 years. That was the end of my first talk. Are there any questions or comments? Thank you.